That's a classic. Happens all the time.
And I know nurses are like the master of handoff.
Most asked question.
Oh my gosh. We'll leave it at that and leave it a little suspenseful. What's going on, everyone? Welcome back to the Med Life. I'm Adam.
And I'm Maddie.
Welcome, Maddie, to the vlog. Today, we're going to be talking about doctor versus nurse and some of the different situations. So to do that, we decided to get these. Exactly. We put a bunch of ideas in this bowl. We're going to pull them out and talk about how a doctor versus how a nurse would handle that situation. All right, Maddie's up first. Grab a scenario.
Okay. Oh, almost got two. Ooh, clean up on aisle blank. Well, nurses do it all. I'm just gonna say it.
I'm not gonna oppose that at all.
I have only had one doctor ever help me clean a patient, and I was like, "Are you sure? Do you want to be in here? Like, you can step out. You can come back when we're done." But for the most part, and it's fine. You guys are busy. That's part of our job, and
I'll take like 1 ounce of credit. More than once, I have helped out. I have not done the whole thing. I have not like physically done the entire aisle cleanup.
The turner? He just helped hold the patient?
I turned, I held, I carried product away.
Okay.
So no booty cream, no actual butt wiping. That's not true, actually. That's happened before. Like if you need to do a rectal exam, sometimes you just have to get it done. But generally, the nurses are totally the heroes. You guys are great. And I've definitely been guilty of saying, I'm gonna come back in a minute. I'll give you a couple seconds to finish up in here. And maybe I should lend a hand more. What do you think, actually? Not to cut you off. Yeah. Drop it down in the comments. Should I clean more butts or not?
If a doctor orders something that makes a patient have to poop, any laxatives, lactulose, anything like that, do you think at least one time in their career they should help clean up a patient?
They probably should, for experience.
Yeah, just to know how to do it.
If you've ever had a colonoscopy, comment down below and let everyone know what that is like. The prep for that is what we're talking about.
Yes, it is.
All right, I'm gonna pull out my first piece. Oh, IV pump beeping.
That's a classic, happens all the time.
Yeah, so. we were talking about this earlier. I literally have no idea. I know exactly what to do to push the silent button. I'm like, don't worry, I'll get your nurse. They know exactly how to fix this.
And I said, don't hit the silence button. Don't even touch it. If something's beeping, I want to go in and deal with it myself. I don't want someone to silence it because chances are they might forget to come tell me. It could be something that's keeping the patient sedated and you just stopped it.
Minor details, right?
Yeah, it could be a pressor and now their map's dropping. So no, I just say, don't touch it. And just let it beep and we'll come in and fix it.
Probably the best practice, but I am curious. So when a pump is going off, it's usually like an air alarm. What does that even mean? Like, I mean, I realize air, but like, what do you do?
So air can go off for two different reasons. One, the med's empty.
Okay, sure.
Antibiotics, all that is good, but pressors, stuff like that, you don't ever want it to run dry.
Too bad.
So that's another thing. Or sedation, yes. Or there could actually just be a bubble in the line. So our pumps, I know every hospital's different, but our pumps have a sensor inside of them, and it will catch if an air is in there. So we just have to detach it real quick, run the line, get the bubble out, and reconnect it.
Okay, so that's what I've seen most of the time. Like when I was flying, and you can check out the video, I'll put the link in the description. I did a shift in the helicopter. The nurses are awesome in there, but the pump alarms are going crazy, and it was just bubbles over and over.
Yeah, no, those can sometimes drive you nuts. I've had it go off like 12 hours, and you change pumps, you change tubing, and no matter what, it just keeps beeping at you.
Painful. Mm-hmm. You're next.
Okay, let's see. All right, change of shifts.
Ooh, okay. So change of shift for us is pretty simple. At least in the ER, we're kind of guilty of doing abbreviated sign-outs. So what the patient came in for, what we've done so far, the things we're waiting on them to come back, and basically what you need to do to either get them admitted or get them out. Now, that's not to say we don't share the important details. We obviously care about the patient, but it's pretty quick compared to what I've seen on the floor. And I know nurses are like the master of handoff with S-bar and all of that. So why don't you tell me a little bit how it is for you?
So, I mean, every, obviously, hospital does it differently. We are given an S-bar format when we start our shift, but 99% of us use our own report sheets. I personally have my own report sheet. We'll link it here if you want to check it out. But basically, very detailed. Start with the patient, why they came in, and pretty much everything that's happened to them since they've come in. So on my report sheet, I literally have a section, and it's just by date, like everything that's happened every single day, and then what's happened in the last 24 hours, and then their current status. And things that are needing to happen, plans, lab draws, anything that's going to be scheduled for the next shift, you want to let them know. But I would say it's a very detailed report.
Yeah,
we
it
only
sounds
have
like it.
1 or 2 patients, and it can be, take us up to 30 minutes to do both.
Impressive. And that's also ICU versus ER. Now, as coming into residency, hopefully, as a fourth-year med student, like, I'm only carrying like 4 or 5 patients at a time. So I know it's a different level than the ICU, but some of our attendings will have like upwards of 15, 20 patients that can be active, especially with boarders. So signing out 20 with 30 minutes at a time, it would never happen.
Yeah, you'd be there all night. You'd be there till your next shift.
That is true. All right. More pain meds, please.
Most asked question.
Oh my gosh. So that's probably different on the floors than the ER, but even in the ED, I get asked so much. Can I give something more for pain? Can I get more pain meds? And I actually find it's like nurse dependent. Like, I have no problem giving someone more pain meds. If they're breathing and they're not like totally snowed and they're in pain, then they deserve to be treated. I'm all about treating someone's pain. I don't believe that just because they're having a lot of a pain and there's an opiate crisis that we shouldn't treat people's pain. That's my own soapbox. But I feel like people freak out about this, and this could be because I haven't had it happen yet, so totally get it. I'm early on. But if someone got, like, let's say, I don't know, 4 milligrams of morphine, and they're like, can I give another 2? I never even question that. Like, in my mind, and same thing, I've seen attendings never really, they're like, 2, yeah, give another 4. They're, as long as they're not like an old person, again, who's like got respiratory depression. But what's it like on your end when the patient's asking directly to you?
Depends on the person. Majority of our people are actually sedated already, so we're giving them continuous pain medicine, so they're covered. But for patients who are awake and asking, it just depends on the situation. If they came in for respiratory issues, we start them off light, we watch them closely, and then if it's something that they take already at home and we've had them off of it, then we usually start it back on because we don't want anyone to go into withdrawals or anything like that. So, but usually we just have to go ask the doctor. We're with the patients, 12 hours, and so are the doctors, but just like what you were saying, like we're at bedside, we can see change in status, change in pain levels, just change in mood in general, and so our doctors are pretty open to us talking and telling them how we think, the pain is for the patient and what we think that they should get.
Cool. You are up, and we're starting to run out.
RSI, also known as rapid sequence intubation. Okay, so for us, usually, patient starts desatting, anything that we need to intubate them quickly, chances are that the doctor is like right there for us, or we can page them, they're pretty close by. They get set up along with our respiratory therapists at the head of the bed, getting ready to intubate, and then as nurses, we get medications ready. So we administer the medications, we pull them up, and then we have another nurse there ready to chart. And then we have a backup nurse if we need anyone to run and get supplies or just anything that we need, they're always there for us. And then, you can talk about the doctor's side. Yeah, no, that sounds really nice.
So I think from our side, it's all about like the patient safety, the patient airway. So when I do get to intubate, especially like an RSI on the floor or in the department, it's not controlled like anesthesia. It's kind of a lot crazier. So you rely a lot on the nurses to have the right meds. You check the meds, you check the labels, make sure the doses are right, but ultimately they're going to be the ones that are oftentimes giving the medication in a lot of the situations I've been in. You rely on your respiratory therapist to have your tube ready, kind of have everything set up. And I always set the suction up myself, check my blade, all of that stuff. And then from there, it's really just a matter of focusing and doing what we know how to do. So getting the patient set up, getting a good look, and then calming the room down. I think a lot of the times that's kind of our role, especially, in a chaotic scene like that, is to get everyone calmed down and get the kind of tone set to do this procedure that's going to be life-saving, hopefully, for this patient. We'll get the tube the first time if everything goes smoothly, and then kind of hand off the role again to the respiratory therapist, who's the expert at kind of getting them hooked up to the vent quickly, and to the nurses who are going to set up sedation and stuff. So I think it's like really a team effort from my perspective.
Yeah, it's interesting that you say that you set up your own section.
Yeah.
Because we as nurses set up our section, at least in my hospital. So every room, we have to have sections set up prior to a patient arriving into the room. So we usually have at least minimum of 2 canisters ready with tubing and a yonk hour, like at all times.
Ready to go. So you have 2 suctions.
We have 2 sections, and then we also have an RSI box with all of our medication that we keep at the nurse's station. Nice. So basically, all our sedation, all of our syringes, needles, we just pull that sucker out. Doctor yells what Maddi needs, and we have it right in front of us.
Very good. So it seems like it's kind of a team effort, and everyone knows their spot.
Yeah.
Cool. My turn. Let's see. Oh, is Grey's Anatomy real life? Is Grey's real life? Do you want to tackle that one? I don't want to tackle that one.
I don't want to tackle that one. I think own. You know, each hospital is different. Each staff member is different.
I was just, I think every person's different. Yeah. I think, I don't want to get like potentially future fired. Graze is not real for everyone. It's like people say like crazy stuff happens on an airplane. It doesn't, like if you've ever flown a lot overseas, it's like nothing crazy is happening.
Yeah.
I think probably people do Grey's Anatomy things in the hospital.
I'm sure they do.
I've never seen it, thankfully. I've never been a part of that, but I'm sure it's out there. I don't know your experience or...
You know, in my hospital, everyone is already married with children, so we are all past that.
Hopefully then, yeah, that's not an issue. So we'll leave it at that and leave it a little suspenseful, but I think it's probably person dependent.
I would say so, and hospital dependent.
Yeah. All right, we're getting down to the bottom. Vent alarms. So what do we do with a vent alarm? I was gonna beat you to it. You're like the queen of vent alarm, probably.
And, I mean, we sit right next to the ventilator, so if it beeps, you're like looking at the patient. You're right there. Each hospital is different, though. We have respiratory therapists right there that also sit there. They have a desk, and our unit is, I mean, it's big, but not big enough that you can't hear something beeping at any part of the unit. So I'd say one, if we're not as nurses right there to answer it, our respiratory therapists are right there. Our doctors will come if it's like an emergency. You know, most of the times we can get there first and figure out what the issue is with the ventilator prior to having to go get a doctor. Usually we can fix the issue before then.
Sure. Yeah, I would say one of the most famous like EM crit care doctors, Dr. Scott Weingart, everyone knows him in the EM world. He advocates that the vent alarm is the one alarm that should never be silenced. Everyone should go check it out because it really can be life-saving for a patient. A vent or a ventilator is the thing that's hooked up to your breathing tube, so if there's a problem with that, there's a problem with the patient's breathing. And a lot of times these patients are sedated. Sometimes they're paralyzed depending on what's going on. So they might not even be able to move to let you know that there's a problem. So it's really important to respond to any kind of ventilator alarm. I think it's probably the same on both sides.
Yeah, it can be disconnected. They could be coughing, waking up, anything like that. You definitely want to check it out.
Absolutely. All right, well, that is it. Thank you everyone very much for checking out this video. We hope you enjoyed it. We had a blast making this.
We did.
Some good laughs along the way. If you enjoyed today's video, be sure to give it a thumbs up and smash that subscribe button. There you go. Keep the bell notification on for when we make more great videos, and trust me, we have a lot of really cool stuff coming. Last thing I want to say before you go, head on over to seethemedlife.com and check out our merch. We've got some really cool shirts, a lot of great stuff you can pick up, and you will soon be able to get an ID holder just like this, along with a badge buddy, all sorts of cool stuff. So check these out, check out the merch. We've got tote bags, t-shirts, all that great stuff. Subscribe, and we'll see you in the next video. You gotta read it. Which one was it? Oh, God.
I can't wait to put that in the greatest highlights.
You went like this.